Good morning. It's a pleasure to be here with you. Well, the title sort of sums it up there. Palliative care and aid in dying, necessary, not mandatory, was really the approach we've taken at UCSF, I think, in contrast to the way it was addressed at Stanford. And yet I think what you'll see is there's perhaps more similarity than differences when all is said and done. So our group really talked a lot about the End-of-Life Option Act as it was being considered in California. One of our fellows, our research fellows, Laura Petrillo, who's a physician now at Mass General, took a very active role in the statewide debate. She testified before the state legislature, was involved in writing editorials, was on the radio, TV, talking about the End-of-Life Option Act. So there was a lot of engagement around it, and including within our entire team. And I think the consensus was that people who request the End-of-Life Option Act need palliative care. I think that was the absolute consensus. There was no question about it. Because it was, but if you look at end-of-life and palliative care, I think what was clear is that we also felt very strongly that palliative care is not end-of-life, and that was really important to our team. We founded our service back in 1999 at UCSF. I remember in the early days when I carried the palliative care pager, someone said, "Oh, you're carrying the no-code pager." As opposed to the code pager, and other things like, oh, we have comfort care suites at UCSF, oh, the rooms at the end of the hall, the death service, things like that. And we've been working very assiduously over many years to really disconnect palliative care from end of life and to really move it upstream. And so there was a concern that somehow now there's this law about how people die, and now palliative care is going to be too intimately connected to it. And so there were a lot of concerns within the team about not wanting that connection to be made too closely. And so we talked about this as a team and decided that we did not want mandatory referral for the End-of-Life Option Act. Unlike at Stanford, people didn't say, oh, everyone should get palliative care, but we clearly didn't want it. And there were also, as at Stanford, many conversations, many meetings among the medical staff around this. But many of us were willing to serve as consulting physicians for most patients. But I will say that's the easy part. Serving as a consulting physician really is not that hard. To say that someone has a limited prognosis and to talk to them about what their options and concerns and fears are, and to say that for the most part they're either have capacity or don't. Mostly it's pretty obvious when they do, as to Tom's point. When they do, they do. It's really clear. When they don't, they don't. That's really clear, and there's a few in the middle. So that was the easy part. Most, but not all, of our physicians were willing to do that, and willing to serve as prescribing physicians really only for long-standing patients. And I think what's been clear is that nobody wants to be the doc who's doing this, and yet people are willing to do it but not have referrals. So what's the UCSF policy? As we developed a policy, we put together a relatively small committee to try and develop the policy, and then got lots and lots of input around it. We were going to be participating. We were a public institution. The president of our university said we should, and we felt strongly we were going to. It was a long process to develop this. When I think about all the time and effort that was spent to develop a policy, it was a lot of time and effort to get this right. There was lots of input. And we knew that it would be a model for the state, which is not to say that we thought we were making a model policy that was perfect, only that other institutions would look to UCSF and ask about our policy. And in fact, that is true. So many other hospitals and institutions across the state have actually turned to UCSF to ask about our policy. The lawyer who helped us develop the policy at UCSF, Susan Penny, used to work for the California Medical Association, and has traveled the state really talking about this topic and sharing her expertise. So we knew that it would be scrutinized. So some details about the policy. We actually developed a medical staff privilege because we wanted to make sure that people actually who are engaging in this, at least one of the two physicians, would actually know something about the End-of-Life Option Act. There's actually a lot of rules about it. And so we developed an educational slide set and a test. So I recently had to do this. You have to get 80% right to pass the test. I can tell you I got 75% the first time, but they do let you take it again, and I passed the second time with 100%. So it's not, but it's a lot of detail. Anyway, I won't go into why I didn't pass the first time, but nonetheless, we wanted to make sure people understood it. I know at Stanford there's sort of an ethics consult that sort of tries to ensure the same thing. I think this is really important. The rules are not simple and straightforward. So at least one of the two physicians has to have that privilege. What do you do if your second physician is outside the system? They don't have our privilege. That works fine. So you can only mandate so far. There's a, quote, mandatory psychiatric referral, psychiatrist or psychologist. This was really based on the idea that there are very few referrals to psychiatry in Oregon and Washington, and also that there's a lot of potential mental health issues in this population, and we didn't want to miss. So this is mandatory. It makes an already burdensome process more so, I will say. So for the first patient who came to me, a 94-year-old woman with recurrent now metastatic lung cancer, who was very clear from the first minute that she wanted the end-of-life option act. She did not want to linger. Good long life, kind of like Gary's patient. She was very clear about this, and we said, well, that's fine. We can talk about it. Her daughter said, yeah, this is my mom, 100%. This is what she wants. I said, well, this is our process, including a psychiatry referral, and that made her the most nervous in the whole process. And she said, do you think I'm crazy? We don't think you're crazy. Are they going to tell me I can't do it? I don't think they're going to tell you you can't do it. This is really just a conversation. They just want to talk to you. This made her by far the most nervous, and it turned out when we really talked about it, it was not really mandatory. And so she did not, in the end, have a referral, but I thought it was very clear that she had capacity and was not depressed. So it's not as mandatory as it seems. And social workers are the point of contact for information. And so social workers have been recruited really for any questions that patients have. When they call to ask a question, they get referred to our social work department and they get connected with a social worker. I can't tell you that it's really a navigator because they don't walk you through the whole process. They're not there to find a doctor who will help you necessarily, but they are there to help patients and provide information. So a little bit about our experience. Few physicians participate. We thought we'd have a list of who's going to participate. Barbara Koenig talked about this yesterday. There is no list. And if there was a list, it'd be a really short list. And nobody really wants to be on the list because no one wants to be known as the person who's the go-to at UCSF for this. I'll talk about this more in just a moment. I think it would be actually a good idea if we did it, but we don't have it. That's interesting. Nearly all patients enroll in hospice. That is true. Pretty much everyone has enrolled in hospice. The process in general is difficult for patients. I would say especially those for neurologic conditions. So I was in clinic last week. I saw a patient with ALS. She can move her right hand a little. She does not have a 6-month prognosis yet. She came in talking about the End-of-Life Option Act. I will say that she was very confused about what it meant. She thought that when the time was right, that I would give her an injection and that would be the end of her life. So she was very confused about it. It did lead to a very productive conversation that I think we were going to have anyway when you show up to palliative care clinic. But nonetheless, she was very confused about what this meant. And my worry for her was that she would not have the ability to complete the End-of-Life Option Act when she, in fact, had a 6-month prognosis. And I will say that in ALS, at least, I've learned a lot by hanging out in ALS clinic as a palliative care clinician, and that I would say most often when people have a clear 6-month prognosis, they are not going to be able to take the medications. They may not be able to swallow, but they certainly are not going to be opening packets of pills and mixing them together and somehow ingesting them. So I think that's a real challenge for many of our patients. I said few physicians participate, none wanted to be identified. That is true. Pharmacies and pharmacist partners are crucial. I think to James's question yesterday, I think that's been essential to have pharmacists that you trust. We have pharmacists both at UCSF, and there are a couple of pharmacies in the Bay Area who participate and are actually incredibly effective partners to us. They will accept the prescription by mail. They will deliver the prescription either the day before or the day of. I can't imagine how you could do this without good pharmacy partners. And if pharmacists won't participate, there is no End-of-Life Option Act, really. And it comes up a lot in all settings, and patients are confused. It's come up on the inpatient setting a lot as well. New diagnosis of cancer in a woman, Chinese speaking, new diagnosis of lung cancer. Literally after the diagnosis, she said, there's this law, and I want that. And I have to say it sort of stumped us about what exactly to do and how to carry it through for 15 days because she wasn't going to be in the hospital all that time. And how would we help her and make the right referrals? She didn't have an oncologist. She had a primary care physician, but it was just felt really hard to manage this for her in the hospital. And What we have found, like everyone, care is key. Why are you bringing this up today is still, I think, the most helpful question. When you think about what lies ahead, what worries you the most? When you look at the future, what do you hope will happen are the essential questions. My recommendations: establish a clear process and support for patients, families, and clinicians. Everyone needs help in this process, clinicians included. Consider identifying a physician or physicians willing to prescribe. I think this would be the best policy at UCSF. If we could find 2 physicians supported by an interdisciplinary team to actually do the prescribing and take referrals, that would be the best. We haven't found that yet. But I think we would develop an expertise in doing this. There would be a clear referral mechanism. There would be a whole process set up. I think that would be really a wonderful way to do it. You do have to trust the clinicians who are doing it. I suspect there's also potential for abuse in a system like that, where it's all concentrated in a few clinicians who perhaps look at prognosis differently or look at capacity differently because they are proponents, perhaps. So I think you have to be cautious, but my sense is that would be much better access for patients and families. Partner with a pharmacy or pharmacist is essential. Partner with a hospice. All the patients at UCSF who have gone through with this have been in hospice, and I think hospices are essential partners. And finally, the palliative care is necessary for all patients who make a request. I think there's no doubt about it. I can say that people are being referred, and that's the good thing. I will tell you that the 94-year-old woman that I took care of who made this request, she came back exactly 15 days later to make her second request, sign the forms. Her daughter was really worried about exactly how this would work, what would happen with the medications, nervous about having them at home. I visited her on Friday evening. She had cracked crab with her family and oysters at her dining room table. That was a Friday night. It was crab season in San Francisco. On Saturday, she got to bed, never got out of bed. Sunday morning, I came to visit her at home to see how she was doing. Her plan was Tuesday night. She was going to take the medication. And on Sunday, I was at her bedside when she took her last breath. Her daughter arrived about 5 minutes later, completely relieved that her mom did not have to complete this, that she didn't have to have the meds, and was she going to be able to swallow it, and so on. So a very peaceful ending in a situation where she was prepared to but didn't need to take the end-of-life option act. I'm not sure what the lesson is there, except that it did lead her to get the care that she really needed and led to good conversations. Thank you very much.